Hoş geldiniz tekrar hepinize.
Hello everyone. Actually, Seçil Bey talked about sleep disorders in the pediatric population. It's a very comprehensive issue, and sleep is a kind of a mystery still. It goes way back in the history, and it has always been an important issue. In my presentation,
öncelikle normal uyku parametrelerini bilmemiz gerekiyor. Normal sağlık.
we have to know the normal sleep parameters. What is a healthy sleep? I mean, a normal sleep cycle is approximately 90 to 120 minutes and is comprised of REM and non-REM periods. And non-REM periods have 1, 2, 3, and 4 stages. And then after 90 to 120 minutes, when sleep starts and the first REM is exposed, 75 to 80% of the total sleep is on non-REM, and REM is characterized with atonia in the in the muscles involved in sleeping. There are many brain activities collaborating together that do result in sleep or awakening. The theory is that the cyclical and homeostatic factors do comprise sleep, and hypothalamus, thalamus, and supracortex are responsible for that. Suprachiasmatic nucleus and lateral hypothalamus are responsible for these, especially they are responsible for cyclical factors. And as the non-sleep stage increases and as endogenous and other cytokines increase, then ventrolateral preoptic nucleus is responsible for forming sleep, and then non-REM and REM sleep stages are formed. I will be talking about the differences in sleep patterns by age from 0 to 5 months until 10 years of age, and there are decreases in sleep duration. 5-month-old child sleeps for 14 hours on average, and the nocturnal sleep is lesser, but the sleep occurs during the daytime. And when they reach at 2 years of age, and there is no daytime sleep, and at the age 4 to 5, again no daytime sleep, and nocturnal sleep takes place, nighttime sleep takes place, and we have delayed sleep phases or stages when the age goes up. The total sleep duration goes down as you age, and Seçil also talked about these percentiles, 10.8 into 15.8 hours is the sleep duration for a child at the age of 2. Here you see that children with daytime naps, the daytime naps decrease as the child gets older. Nighttime sleep duration is very intensive in the first 3 months of life, and then in time, nighttime sleep duration also goes down. Again, daytime sleep duration goes decrease or goes normal as you age. When you also see the distribution of sleep, the total sleep duration, and this is a trend, goes gradually down. In 74, 79, and 86, in these years, these studies were conducted, and we see this decreasing trend. Again, the bedtime and wake time also changes. I mean, there are decreases in nighttime and increases in daytime. You see that the brain develops, and this creates some other changes in the sleep patterns. Between 6 to 12 months, electrophysiological differentiations can be made in non-REM sleep. 50% is REM sleep in babies, and REM sleep decreases as you age. For 3 months, it's 40% of the total duration of sleep. For 3 to 12 months, it is 30%. And up until 10, delta sleep increases by the age of 10, and then normal REM or adult REM durations are achieved as you age, starting from the year 10. And the basic waveforms are not changing as adolescence starts. Moreover, sleep latency is shortened. From awakening to sleep, the duration in between is shortened. There was a study that showed that after 40 hours of sleep abstinence, the first time that you sleep, there are intensive delta waves increasing. When the nervous system develops at an early phase, and sleep are encouraged by plastic processes for newborns, and they sleep more, and at the age of 10, REM sleep reaches to the duration of an adult. Intrauterine and premature babies have a brain activity completely like REM stage. Sleep is important for reorganizing the memory and making it permanent. There are studies showing that, but they focused on REM due to their connection with dreaming. And during these studies, it was reported that the REM duration increased. REM sleep increase after education takes place, especially during very challenging tasks, and when the education or training is completed, it is not manifested. And in some studies, there are increases in non-REM processes. So in some studies, this REM and sleep duration increases due to right after education, and then there is delay in some other studies. This is REM sleeping window. So in some studies, prism glasses are used that result in 90 degrees of shifts in the visual space of an individual. And in order to adapt yourself to these visual and spatial changes, and the REM duration increases by 3%. Again, REM and non-REM cyclical numbers has a positive correlation with memorizing a list of words. Again, this is also valid for maze as well, a maze learning test. Motor ability acquisition also has a positive correlation with REM sleep duration. In visual and oral training, there is no such a correlation with them and non-REM duration. There were a group of researchers that wanted to look for the relationship between learning and REM, and then compared to those students who are working for an exam and who are not, or studying for an exam and who are not. And then the one who are studying for the exam have intensive REM sleep. Texture discrimination task and texture discrimination test was used in order to evaluate motor abilities, and together with the education, performance increase, and the first night sleep after training also increases this education. And then and the subjects that were left without a sleep and did not show as effective as it was when compared to the first group who slept the first day after education. Sickles and friends, thanks to this texture discrimination method, showed that this performance was very important, and it was then sleeping after education was very important to strengthen the knowledge. International Classification of Sleep Disorders suggests that there are 8 main groups comprising 85 disorders which are not included in the DSM. So according to ICSD, there are 85 disorders, as I said before. So in summary, you can see on the slide insomnia, respiratory problems during sleep, hypersomnia due to non-respiratory reasons, circadian rhythm disorders, parasomnias, and sleep-related mobility disorders, normal variants, isolated symptoms, and other sleep disorders. It's much harder to differentiate these when compared with adults. I will be talking about insomnia, behavioral insomnia during childhood. There might be 5 subheadings to that. One is difficulty sleeping, difficulty maintaining sleep, and extraordinary behaviors during nighttime, and sleepiness in daytime. American studies suggested that the prevalence of these disorders 20-30%. In Asian countries, this goes up. In Taiwan, 500 children and parents were involved in the study, aging 0 to 6 years old, and 38% had very frequent awakenings during nighttime. 70% have them difficulties in sleeping. I mean, it has to pass 30 minutes have to pass for them to sleep. In China, 66% of those had difficulties in sleeping. They wanted to have mothers, for example, with them as they fall asleep. So 1/4 of babies report to have have problems with regards to awakening more than 5 nights a week. 8-month-old babies that have sleep problems have been monitored, and 41% of these still have similar problems during the age of 3. Again, 84% of this group was, and 84% of those children also monitored, and still their problems continued 3 years later. And then those children at the age of 8 were followed, and 40% of these children that have sleep problems, when they were reviewed, they had these problems at the age of 3. So, and actually, when you do not treat this, when you do not study this, this might go on for several years during childhood. And the most common age when you see behavioral insomnia is between 6 months to 3 years old. Some unwelcome sleep patterns like watching TV and sleeping together with the parents, they are the reasons for that. And infant, preschool and school children are the group that has been most affected with this phenomena, especially in US, and there is this Sleeping Medical Academy in US, and they created this intervention protocol, behavioral intervention protocol for this group, and their efficacy is 94%. Extinction, graduated extinction, and positive sleeping routines, planned awakenings, and parent training methods are used. In the extinction method, it is kind of a challenging method. It's difficult for the parents to say no, actually, and then screaming and wanting parents to be with him should be ignored. Graduated extinction, again, depending on what parents can stand, these calls might be responded by the parents in certain intervals, but there should be a gradual step here. I mean, all these calls should be gradually not responded. And then these extinction and graduated extinction methods are depending on the extent of saying no by the parents, and depending on that number of applications, of course, the success rate, of course, changes. So it's up to the parents. A calm and good routine, happy routine is encouraged. Massaging and bathing, they are recommended, and if these take place, there is good success rate. Plant awakening, the child can be awakened before the planned hour, and sleep hygiene rules should also be told to parents, and improving parents and child's relationship is important, especially as infants. Sleep also represents a time of dissociation from the parents, so it's very important to make sure that the child has a good or a positive association with sleep. So interaction between parents and babies or child are important for behavioral insomnia, and the repetitive awakenings are much more common for those who sleep on their own bed. The temperament of the baby, nutrition, physical disorders, milk allergy, and marriage dispute, and psychopathology of parents do have an important relationship with behavioral insomnia. For those who are breastfed, they do awaken during the nighttime much more when compared to those who are fed with baby food. Behavioral protocols are successful. These are illustrated with certain studies. There are many studies suggesting that these protocols do have important efficacy. In this slide, nighttime sleep duration improved, they're increased when these protocols are administered. Can you please wrap up? Yes, I am about to. And then the frequency of awakening during nighttime is decreased. In the pediatric group, there is an increase in prescription for the sleep disorders, and 81% of those patients that have pediatric insomnia are prescribed a drug, and 33% are antihistaminics, and 26 alpha-agonist probably clonidine, and 15 benzodiazepines, and 6% antidepressants, and 1% non-benzodiazepines, and 48% is the rate of prescription for adults. When we look at the physicians reporting at least one prescription medication recommendation for children's sleep, again, antihistamine and diphenhydramine, antidepressants 16%, antipsychotics, benzodiazepine. So all those are very well prescribed, at higher levels. So non-prescription and prescription, non-prescribed drugs use is also high, but they are used for lesser days. Prescription and drugs benefit is of course higher. Again here, antihistamine is prescribed at higher levels. Diphenhydramine, I think this is interesting because the study suggests that there is no difference between diphenhydramine and placebo. Again, different drugs and their impact on sleep levels is examined, especially during REM. Sleep latency is decreased by all drugs, and total sleepiness is increased. But percentage of REM is decreased. Thank you very much for your patience.